Hello friends, welcome back to my channels Medicine of on Zero On. Today we will talk about preterm labor. So it's one of the important topic as far as the obstetrics is concerned, right? Now see, I have started over here that the preterm labor. Normally, what do you mean that if the labor starts before 37 weeks? Now normally, what's the normal range of the term labor? That is the what? 37 to 42 weeks. So with the, if we get to see the starting of the labor before 37 weeks, that will be considered as the preterm labor, right? Now there are some time limits, so let's have a look over here. Now, if the labor starts beyond 42 weeks or after 42 weeks, that will be considered as postterm labor. If the labor starts, beyond 40 weeks, but before 42 weeks, beyond 40 weeks, but before 42 weeks, then it will be considered as past days, right? And if it starts before 37 weeks, as I have mentioned over here, the today's topic, that's the what preterm labor. And if the labor, if the labor starts before 32 weeks, that is known as severe preterm labor. That is known as severe preterm labor. If the labor starts in between 32 to 34 weeks, if the labor starts in between 32 to 34 weeks, then it is known as usual preterm labor. It is known as usual preterm labor. But before 32 weeks, that is known as extreme or the severe preterm labor. Another one is over here. If we get to see the list, the labor, if we get to see the starting of the labor more than 34 to 36 weeks plus 6 weeks, right? That is known as late preterm labor. That is known as late preterm labor. Now another important data you can remember from here, that normally around at 40 weeks, the 40 weeks, that is considered as the EDD, that means the expected delivery date, right? Now how can we understand, yes, the pregnant woman, they don't know the labor pain has started. How can we diagnose it? So we can diagnose normally, what do you know, there will be the presence of the abdominal pain. Now the abdominal pain that can be present for the multiple other regions, right? Now how can we be accurate about it? So for example, there may be, if we get to see the small bowel movement over here, for that thing we can get to see the abdominal pain, the cramping, abdominal crampness over here. Now how can we diagnose on the basis of this thing? Now if we get to see the uterine contraction, if we get to see the uterine contractions fast on 4 times in 20 minutes, 4 times in 20 minutes, or if we get to see the uterine contractions 8 times in 1 hour, 8 times in 1 hour, then you can just have the confirmations, yes, the labor has been started, right? Now another important thing you can remember from here, that on per vaginal examinations, if we get to see that the cervix is 1 centimeter or more than 1 centimeter is dilated, right? So normally what do you know, if the length of the cervix is more, if the length of the cervix is more, then it will take more time to flap up. If the length of the cervix is less, or a shorter cervix, if you get to see the short cervix for example, then it will take less time to flap up. So if the length of the cervix is greater than equal to 1 centimeter or more than equal to 1 centimeter, or if you get to in terms of the dilation, so if the cervix is dilated more than equal to 1 centimeter, then you can get the confirmation about the the preterm labor. Or if you get to see the 80% of the cervix is affected, another conditions if we get to see, it's very important on the number third on, that if the cervix is more than 3 centimeter dilated, if the cervix is more than 3 centimeter dilated and 80% of the cervix is affected, 80% of the cervix is affected, then we consider this thing in terms of advanced preterm labor. And if the length of the cervix is less than 3 centimeter and less than 80% of the cervix is affected, then it is known as early preterm labor. So what did I say? If the length of the cervix is more than 3 centimeter dilated plus 80% of the cervix is affected, then it is considered as advanced preterm labor. If the length of the cervix is less than 3 centimeter and less than 80% of the cervix is affected, then it is considered as early preterm labor, right? Now another condition, if we get to see that 1 centimeter dilations of the cervix and less than 80% is affected, less than 80% of the cervix is affected, at that time, just for the confirmations, we have to go for cervical examinations. We have to go for the cervical examinations, right? So we have to go for transvaginal sonography. We have to go for transvaginal sonography. On that diagram, we'll get to see on the cervix. On transvaginal sonography, we'll get to see if the length of the cervix, is less than 2.5 centimeter, that means yes, the labor pain has started, or we can say that there is a chance to develop the preterm labor. And on the transvaginal examinations, sorry, I was not supposed to say here that the labor pain has started. So around at 12 weeks, if we do the examination, or around sorry, let me correct it myself. Okay, now if during labor, if we get to see by the transvaginal sonographical examinations on the cervix, if the length of the cervix is less than 2.5 centimeter dilated, then it is known as a threatened labor. If the on transvaginal sonographical examinations on the cervix, if we get to see the dilations of the cervix is more than 2.5 centimeter, then it is known as false labor. So what did I say? Please mark my word. On transvaginal sonographical examinations, if the length of the cervix is less than 2.5 centimeter, then it is known as threatened labor. If on transvaginal sonographical examinations, the length of the cervix is more than 2.5 centimeter, that means it is nothing but the false labor, right? Now we'll talk about what are the causes that can cause the preterm labor, right? So first, I'll write it over here. The causes of preterm labor. What are the causes of preterm labor? So first, the most important, or rather you can say that's the infections. Okay, so first one, the infection. So infections near about cover 20 to 25% causes of the preterm labor. So the first one, I'll write it over here, the infections. There are some bacteria that can cause this type of the conditions. So let's know about the name of the bacteria. So first, chlamydia. For example, the gonorrhea. Okay. E. coli. You can remember the streptococcus. Okay, so there are more, the different kinds of the bacteria that can cause the preterm labor in terms of the infections, right? Yes, another important one, ureaplasma. So you can remember plasma. So these are the different kinds of the bacteria that can cause the preterm labor, right? Now we'll talk about that. Okay. Another important thing, if we get to see that development of the chorioamnionitis, for example, if we get to see the development of the chorioamnionitis, at that cases we'll get to see the different kinds of the what changes. Now, on the basis of that particular changes, you can also get the confirmations of the preterm labor. Let's talk about those things. Okay. Okay. So more important, you can remember in terms of the cause, mycoplasma, the bacterides, and the trichomoniasis. So these are the the causes that can cause these are the microorganisms that can cause the preterm labor. Now we'll talk about chorioamnionitis. So on the basis of the chorioamnionitis, what kind of the changes we'll get to see over here? Okay, let's talk about those things. The second cause, chorioamnionitis. So what are the causes? what are the parameters by which we just detect the chorioamnionitis? Of course, if we get to see the development of the chorioamnionitis, there is a chance to develop the preterm labor. So as we know, it's an inflammatory disease. So of course, here we will also get to see that uterine tenderness, uterine tenderness. Along with that, we can also get to see that C-reactive protein that will be elevated, inflammatory process as we know it. Right. The pulse rate. Let me write it clearly. Let's use different color for it. Okay. The pulse rate, it will be increased. Along with that, we'll get to see also that total leukocyte count, the TLC, or the leukocyte count, that will be increased, right? As we know, it's the inflammatory process or inflammatory conditions in which we are supposed to get the value of the total leukocyte count, that will be increased. So we can write it over here. Leukocytes, that will be increased. Another important one, we can get to see the foul smelling because of the rupture of the chorioamniotic regions. Right. And you can remember one value from here, that the value for this one, that will be more than 2.5. Okay. So what are the conditions, or what are the changes we'll get to see in terms of the chorioamnionitis? So in chorioamnionitis, they have written over here 4 or 5 criteria. Okay, so first one, the uterine tenderness. The second one is the C-reactive protein. The value for the C-reactive protein, that will be elevated. The pulse rate, that will be also increased. The total number of the leukocytes, that will be also increased. Along with that, okay, we get to see foul smelling discharge. So the discharge through the vagina, of course, we'll get to see what this kind of the conditions. Now, what did I say? As far as the causes are concerned of the preterm labor, the first one I have written over here. There's the infections that covers near about 20 to 25% of the causes of preterm labor. The second one I have written over here is the chorioamnionitis. So what are the criteria? What are the changes we'll get to see whenever the woman, she will develop the chorioamnionitis? So on chorioamnionitis, as it's the inflammatory process, I'm repeating once again, as the chorioamnionitis, it's the inflammatory process. Here we'll get to see the elevations of the C-reactive protein. The second one, we'll get to see the uterine tenderness. The third one, the total leukocyte count, that will be increased. And along with that, the pulse rate, that will be also increased. And here we'll get to see also the foul smelling discharge. So any of these two, if we get to see the presence of any of two is positive, any of two out of this 5, for example, is positive, that will be the diagnostic for preterm labor, or that will be the diagnostic for chorioamnionitis, and chorioamnionitis, that can be the cause of preterm labor. Okay. Now we'll talk about the other causes that can cause also the preterm labor. Okay, let's read some portion from here. Okay. If we get to see that over distended uterus, okay, so in that cases we can get to see also the preterm labor. Okay, so let's see this portion. I'll write over the causes. Okay. Okay. So if we get to see over distended, let's write it over in normally. Uterine over distension. So if we get to see the uterine over distension. So whenever the size of the uterus, for example, that will be increased for whatever the regions, that can cause also the preterm labor. So what did I say? That if you get to see the uterine over, uterine over what? Distensions. If you get to see the development of uterine over distensions, and what are the causes that can cause the uterine over distension? So the causes that can cause the uterine over distensions, the first one we can write it over here in terms of the polyhydramnios. So polyhydramnios. The second one, if we get to see the large baby, okay. So that can cause the uterine over distensions, and further the uterine over distension that will cause the preterm labor. So what are the causes? The polyhydramnios, the large baby, and also yes, if we get to see the twins. So twine. So in this, these are the causes that can cause the uterine over distension, and the further uterine over distension that will cause the preterm labor. Hope it's clear for you, right? Now we'll talk about the other regions. Okay. If we get to see the uterine abnormalities, uterine abnormalities. So the different kinds of the uterine abnormalities, that is, those are also responsible for the preterm labor. So what are the abnormalities you can get to see? So first one, if we get to see the septate uterus, for example, or if we get to see the biconvate uterus. So if you get to see the septate uterus, or if you get to see the biconvate uterus, in these conditions, these are the abnormalities of the uterus, and these are also responsible for causing the preterm labor as well, right? And the other regions, okay. The maternal fetal stress, this is also another region. The maternal fetal stress. So the maternal fetal stress, that is also another region that can cause also the the uterus, that can also cause the preterm labor. If you get to see, for example, that the bleeding, if you get to see the bleeding where within, or bleeding in, rather you can say in choriodecidual space. If you get to see the bleeding in the choriodecidual space, that can also cause that will just compress, and that can also induce the preterm labor. That can also induce the preterm labor. So bleeding within the choriodecidual space. So this is another region that can also cause the preterm labor, right? So what are these are the causes: the infections, the chorioamnionitis, the uterine over distensions, and the uterine abnormalities, and also the bleeding within the choriodecidual space. Okay, another regions you can write it over here: the cervical abnormalities. So as far as the cervical abnormalities are concerned, what can you get to see over here? If you get to see that that's ulcerations, or you can say the lacerations of the cervix. So cervical lacerations, or if you get to see the incompetent cervix. So these are the regions that can cause the preterm labor. So what did I say? As far as the causes of preterm labor is concerned, at first we'll get to see the infections that covers near about 20 to 25%. So there are the different kinds of the microorganisms that can cause the preterm labor. So if we get to see over here, there's the chlamydia, the gonorrhea, the E. coli, the streptococcus, the mycoplasma, the bacteroids, and the second region, as I said, that the chorioamnionitis that can also cause the preterm labor. Within the chorioamnionitis, as I said, it's the inflammatory process where we'll get to see that elevations of leukocyte values, elevation in the C-reactive protein values. Along with that, we'll get to see the elevation in the pulse rate. Along with that, also you'll get to see the uterine tenderness and the foul smelling discharge. So any out of this five, if we get to see any two out of this five get positive, then we can get the confirmations of the chorioamnionitis over here. Okay. So this is also responsible for the preterm labor and the uterine overdistensions. If we get to see the development of uterine overdistension, if there is the presence of uterine overdistension, that can also be the cause of preterm labor, right? So what are the causes that can cause the uterine overdistensions? As I said over here already, that the first reason that can be for the polyhydramnios, if we get to see the twins over here, or if we get to see the large baby. So these are the reasons that can cause the uterine overdistensions. Further, it will cause the preterm labor. So these are the labors. Now we'll go back for the more diagnosis. How can we diagnose on the basis of the ultrasonography and the different kinds of the laboratory markers, right? Okay. Okay. Rather, I can write it over here. The prediction of preterm labor. So what are the predictions by which you can also get the confirmations of the preterm labor, right? First, we can go for the ultrasonography. On the ultrasonography, if we just do for the 2 times around at 12 weeks, the first one, and the second one, if we do around 28 or 29 weeks, okay. So what type of the changes we'll get to see over here? Let's talk about those things, right? Okay, let's write it over here. Okay. So the first thing, what did I say? How can we just do the predictions of the preterm labor? If we do the ultrasonography around at 12 weeks, so at 12 weeks, where we'll get to see the length of the cervix, that will be less than 2.5 centimeter, okay. And if the length of the cervix is less, then it will flap up easily, right? That will cause the preterm labor. The second thing, the second ultrasonography you can do around at 29 weeks, for example, where we get to see the funneling of, it is very important guys, funneling of what? Cervix. Here we get to see the different kinds of the funneling. The T shape, it's normally, we can get to see the V shape, we can get to see the U shape of the funneling of the cervix. So what did I say? How can we do the predictions of the preterm labor? We can go for the ultrasonography. We have to do the ultrasonography around the first one. We have to do the ultrasonography at first around at 12 weeks, where we will get to see the length of the cervix, that will be less than 2.5 centimeter. Another ultrasonography you have to do around at 29 weeks, where we will get to see the funneling of cervix. The different kinds of the shape we will get to see over here. The T shape, it's the normal conditions. We can get to see the V shapes. We can get to see also the Y shapes or U shapes. Another one is Y shape, right? Okay, another the laboratory diagnosis you can go. Lab diagnosis, for example. So during the development of the choriodecidual junction or the choriodecidual regions, at the time we will get to see that within the vaginal discharge, rather we can say within the vaginal secretions, we'll get to see one kind of the protein, glycoprotein. So what did I say? As far as the laboratory value is concerned, we'll get to see one kind of the glycoprotein that is known as fetal fibronectin. So basically that is found before 22 weeks and after what? 37 weeks. Right? What did I say? Okay, let's use the different color for it. what did I say? That as far as the laboratory value is concerned, we can go for the fetal fibronectin. Fetal fibronectin. So the fetal fibronectin, what did I say? As far as the lab value is concerned, the fetal fibronectin during the development of the choriodecidual junction or the choriodecidual regions over here, we'll get to see within the vaginal secretion, we'll get to see the presence of fetal fibronectin. Now this fetal fibronectin that is found basically before 22 weeks, and after 37 weeks, but if we get to see the presence of the fetal fibronectin within the vaginal secretions in between 22 to 37 weeks, that may be also the diagnostic, or that will help us to predict whether the woman can have the preterm labor or not. So this is a fetal fibronectin, another kind of the glycoprotein. There is the laboratory values you can get over here that will help us for the diagnosis of the preterm labor, right? Okay, let's continue. So these are the diagnosis. I should say the predictions. We have to do the two ultrasonography at around at 12 weeks, around at 29 weeks, and we have to check out for the length of the cervix over here and the shape of the cervix, right? So these are the findings we can get to see in the predictions of the preterm labor, right? Now we'll talk about the what kind of the complications we'll get to see in terms of the newborn. Okay. Before that, I'll talk about little bit of the maternal complications, then I'll go back to the neonatal complications. So if we get to see the development, if we get to see, what did I say? If we get to see the development of preterm labor, then what kind of the complications that can be found in case of the mother and in case of the neonates, right? Let's talk about all these things step by step. At first, I'll talk about the complications that can be found in mother for the development of preterm labor, right? So, maternal complications. Maternal complications. So what kind of the complications we can get to see over here? The first one, we'll get to see the endometriosis. Okay. Endometriosis. Second one, we'll get to see puerperal sepsis. So these are the complications we can get to see in terms of the mother, right? Okay. And the most important one, we'll have to talk in terms of the neonatal complications. So what are the complications that can be found in terms of the neonate for the development of preterm labor? Okay. So what did I say? If we get to see the case of preterm labor, if we get to see the case of preterm labor, then what kind of the complications we can see in terms of the neonate? So, or rather I would say that what are the neonatal complications for the development of preterm labor, right? So the neonatal complications due to preterm labor, the most important on we'll get to see there is the respiratory distress syndrome. Another name for it, what is that? That is the hyaline membrane disease, right? So the first one, we'll get to see the respiratory distress syndrome. Another one is the hyaline membrane disease. The second one, you can get to see the intraventricular hemorrhage. So intraventricular hemorrhage. The third one we can get to see the bronchopulmonary dysplasia. The third one we can get to see the bronchopulmonary dysplasia. Bronchopulmonary dysplasia. The fourth one we can get to see the neonatal death. This is nasty one. So these are the complications we can get to see as far as the neonate is concerned, right? Another one you can add over here, that's the necrotizing enterocolitis. Necrotizing enterocolitis. So what did I say? Please listen to me very carefully. If we get to see the development of preterm labor, in case of preterm labor, what are the complications that can be found in terms of neonates? So I am repeating once again because this is very important. So what are the complications that can be found if we get to see or due to the development of preterm labor? So in preterm labor, the complications that can be found in terms of the neonate, what are those? Those are the first one, as I said, the respiratory distress syndrome or okay. So let's continue. So in neonatal complications, the neonatal complications due to preterm labor, as I said, the neonatal complications due to preterm labor. The first one, the respiratory distress syndrome, another name for it, this is the hyaline membrane disease. We can get to see the bronchopulmonary dysplasia. We can get to see also the intraventricular hemorrhage. We can get to also see the neonatal death and also the necrotizing enterocolitis. So these are the complications that can be found due to what? Preterm labor, right? Okay, now we'll talk about the management. It's very important. Okay, so how can we manage the conditions of the neonatal complications, of course, due to what? Due to the preterm labor. So let's talk about those things. So, okay, I'm erasing this person away. Okay, so the management. So as far as the management is concerned, as we know, if we get to see the preterm labor, that means the lung that will be not developed properly, will not get to see the lung maturity. So if there is if there is not, if there is no lung maturity, that means there will be the problem. Now, just to mature the lung, we can use the steroids. So as the first line drug in terms of the preterm labor, just for the survival of the neonates, just for the survival purpose of the neonates, we can use the what? Steroids. The first line drug, that will be the steroid. Of course, we can use the tocolytic drugs, but before that, we have to go for the steroids. So the management, we have to use the steroids. So what kind of the steroids we can use? We can use the dextromethasone, the first, okay. Let's write it over here. In terms of the management of the preterm labor, just for the survival purpose of the neonates, we can use the steroids for the maturity of the lung, right? The first one, we can go for the steroids, and within the steroids, which one is the best? There is the dexamethasone. So dexamethasone we have to use 6 milligram 12 hoursly and for 4 dose. Right? So what did I say? That for the maturity of the lung, or rather we can say for the survival purpose of the lung, for the survival purpose of the neonates, we can go for the steroids for the lung maturity, of the neonates, we can use the first line drug, that is the steroids, right? So within the steroids, the first drug we can go for the dexamethasone 6 milligram 12 hours. Apparently for 4 dose we can use over here. Another one is the betamethasone. And that is 12 milligram 24 hours apart or 24 hours leave, and 2 doses we have to use for it. Alright. So let me repeat it once again, it's very important. Okay, so what did I say? That as far as the management of the preterm labor is concerned, for the lung maturity of the neonates, we have to use the first line drug in terms of the steroids, right? So we have to use the steroids, and within the steroids, the first line we can go for the dexamethasone 6 milligram 12 hours separately and for per dose. And the betamethasones we can also use 12 milligram 24 hours sleep for 2 doses. Of course, we can use intravenous or intramuscular. Apart from that, if the lung is not matured, for example, after delivery, if we get to see that we have gone for the intubations, for example, we have gone for also that the ventilations, and we have also used the oxygens. After that, we are getting to see that condition is not getting that good. The condition is not getting good. Rather, if the condition is going worst, okay, as time passing by. So after that, we have to go for the artificial surfactant. So surfactant, artificial surfactant. We have to use artificial surfactant. Now here we can use that Cervanta. There is the bovine source from the animals. From the animals, nasal discharge. So Cervanta, the bovine source, or you can go for S. Okay, let's write the name. Yes, little. Yes, exosurf, 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 and Alice. So what did I say? For the lung maturity, at first we have to go for, in terms of the preterm labor, for the lung maturity, at first we have to go for the steroids. Within the steroids, at first we have to use the dexamethasone 6 milligram 12 hours separately for 4 dose, or the after that we can also use for the betamethasones 12 milligram 12 hours separately for the 2 dose. Okay, so after using these things, and for after delivery, you have gone for the ventilations, we have used too much oxygens. After that, if we get to see the condition is not getting good, at that time we have to use the artificial surfactant. Within the artificial surfactant, we can use the Cervanta, the bovine source, and of course we have to use this one through the intrabronchial route. Intrabronchial route. Okay, so we can use these drugs. Apart from these, we can also use the calcium channel blocker that will not let the muscles, internal muscles, to contract, so that will not let to cause the preterm labor. So what did I say? You can also go for the the calcium channel blocker. You can also go for the using of the progesterone. You can also go for the oxytocin antagonist. Okay, so the different kinds of the drugs you can use that will not help the muscles to contract. Okay, let's talk about all those drugs step by step, right? So let's talk about those drugs. Okay. So as far as the tocolytics drugs are concerned, so what kind of the drugs we can use? So we try to understand the tocolytic drugs. Of course, we can use, but if we just see the left phase of the labors, if we get to see the phases of the labor, if we get to see the phases of labor, in that cases we'll get to see that within the latent phase. For example, if I show you the phase of the labor, okay, Here, for example, the cervix is 3 centimeter. Here it is, for example, 7 centimeter or more than 7 centimeter. This phase is known as the latent phase. Latent phase. Within the latent phase, we can go for what? The tocolysis or the tocolytic drugs. So the tocolysis or the tocolytic drugs that can be used where within the latent phase, not beyond the latent phase, right? So what are the drugs we can go for within the tocolysis? First, we will go for that beta agonist. We can go for salbutamol, as you know. Alright. But the problem is over here. What's the main problem? Okay, let me repeat that thing for it. So retrodrine, salbutamol, retrodrine. We can also use the retrodrine, and another important one. Yes. Sorry. Anyway. Now see, what did I say? Within the tocolytic drugs, at first we can go for the beta agonist. Within the beta agonist, we can go for the salbutamol, retrodrine, or isoxaprine. Okay. But the main problem, what is the main problem over here? What is the main problem over here? That the salbutamol and the retrodrine, this beta agonist, that can cause what? That can cause the glycogenolysis, or that can also cause the lipolysis. Ultimately, the side effect, rather we can say, we get to see the development of the hyperglycemia. And also for this drug, we can also get to see the development of pulmonary edema. We can get to see also. Okay, so you can go for the beta agonist, the salbutamol, retrodrine, or isoxaprine. Okay, anyway, whatever, you just remember the spelling, that's enough, I think. After using the beta agonist, you can also go for the calcium channel blocker. Within the calcium channel blocker, we can go for the nifedipine. The nifedipine that will not let the muscles to contract, but the side effect also you get to see over here. And you'll be able to understand the drugs are given. So you can go for the calcium channel blocker, the nifedipine. The side effect what? Here you also get to see the pulmonary edema. Another important drugs you can use for the antagonizing functions of the calcium. We can go for the magnesium sulfate. We can use MgSO4. See, MgSO4 that will antagonize the calcium. As a result, we'll get to see that the muscular contraction that will be not over here, the severe muscular contraction that will cause the preterm labor. Okay, that will just stop the muscular contractions by inhibiting the function of the calcium. But here the side effects will get to see also is the hypomotility of the fetus. Okay, these are the side effects. And also we can go for the progesterone. As we know, the progesterone, there is the muscle relaxant, is the muscles relaxants, right? That can relax the muscles. So we can also go for the progesterone. We can also go for antagonize functions of oxytocin. For example, if we get to see any kind of the drug that will antagonize the function of the oxytocin, we can also go for that drug. Okay. And atosiban. So what did I say? As far as the drugs are concerned, at first we can go for the beta agonist in terms of the tocolytic drugs. In terms of the tocolytic drugs, okay, in case of the preterm labor, in case of preterm labor, we can go for the tocolytic drugs. The first drugs we can use the beta agonist. The second one we can go for the calcium channel blocker. The third one I have said over here that antagonized functions of the calciums. For that thing we can use the magnesium sulfate. We can also go for the progesterone, and we can also go for the anti functions of the oxytocin. That is nothing but the atosine. Oxytocin or antagonized function of the oxytocins. But this drug is not able to reduce the mortality and morbidity of the fetus. Okay, so here no mortality, no morbidity, this kind of the functions is not done by this kind of the drugs. There is no relations in terms of the morbidity and mortality of the fetus by using the atosine. Okay, then you can also go for another drug, for example, okay. So the last one we can go for yes, we can go for what is the name of that drug? Yes, prostaglandin synthesis inhibitor. That's very important one. Prostaglandin synthesis inhibitor. So prostaglandin synthesis inhibitor, you can also go for the prostaglandin synthesis inhibitor. For that thing we have to go for the NSAIDs, and within the NSAIDs you can use, for example, the indomethacin. You can go for the using of the indomethacin. So you can use this kind of the drugs. So what did I say? As far as the management is concerned, at first we can go for steroids. So after using the steroids on the latent phase of the labor, we can go for the tocolytic drugs. We can go for the tocolytic drugs within the latent phase of the labor, right? At first we can go for the beta agonist in terms of the salbutamol types of the drugs. The second one we can go for the calcium channel blocker, for example the nifedipine per year. The third one we can go for the magnesium sulfate that will antagonize the function of the calcium. The fourth one you can go for the progesterone, as you know that will cause the relaxations of the muscles, or relaxations of the muscles. Then we can go for the antioxidant in terms of the atosine, and the last one we can go for the prostaglandin synthesis inhibitor. Here we can go for the NSAIDs, just for example the indomethacin, that will not let the prostaglandin to get produced, so the functions of the prostaglandin that will be stopped, right? So these are the managements we can go for this kind of the drugs. Okay, and dioxide we can also go for dioxide, and also we can go for nitric oxide donors. Yes, nitroglycerin patch. Yes, nitroglycerin donors. Nitric oxide patch. Yes, of course, nitroglycerin. It will be nitric oxide donor. That means nitroglycerin patch. Nitroglycerin patch. Here you can use 0.2 to 0.4 mg per hour. Yes. And at last we can go for also the dioxide. So before using the dioxide, because it will cause the hypotension, right? It will cause the hypotension. So before that thing we can use 500 to 1 liter of the ring electrode solution. After that, after giving that, we can go for the dioxide. That will cause the hypotension in terms of the side effect. So these are the drugs we can go for the management of the preterm labor, and I have already explained in another video how can we just test the lung maturity, as in sphingom myelin lecithin ratios, all these things, and the SEC test, Nile blue test, everything is over here. Okay, so see you in the next video very soon. Thanks for watching.